Welcome to How's That Working For You, a podcast for the therapy curious. I'm your host, Dr. Zoe Krupka. If you're working in one of the many fields of mental health, we've made this space for you. Come join us in some reflection on these often very strange jobs that we do, in the hope that we can really get to the heart of how to improve our work and our own sense of how to be who we are within it. This podcast is brought to you by the Cairnmillar Institute. Cairnmillar is founded on the unceded lands of the Wurundjeri people of the Kulin Nation. We pay our respects to their elders, past and present, and acknowledge their deep, enduring connection to land, waters, and community. The legacies of colonization and the ongoing effects of institutional racism have enduring effects on the mental health and well-being of First Nations people, and we hold this continuing dispossession in our minds and hearts as we explore the question of how to improve our work in the mental health field. Cairnmillar is more than just a not-for-profit organization. It's a vibrant community of students, clients, staff, alumni, and generous donors. Our hearts beat for better mental health, which has driven us for over 60 years. At CMI, we believe in a dynamic interplay between training, research, and clinical practice. These three pillars from our triple helix, each strengthening and informing the other. As a registered health promotion charity, we've been pioneers in counselling and psychotherapy in Australia. Our purpose is to enhance mental health through accessible psychological services and innovative professional education. That's where How's That Working For You comes in. This podcast is our way of sharing the extraordinary insights, anecdotes, and life lessons from the mental health field. We're pulling back the curtain to offer you a unique peek behind the scenes, aiming to deepen your understanding of this remarkable space. I'm a senior lecturer at CMI. I'm a feminist psychotherapist, supervisor, and researcher. I've worked in agencies, organizations, and private practice. I've trained in a number of modalities, including emotion-focused therapy and existential psychotherapy, and I have a primary interest in anti-oppressive practice. Today's guest is George Habib. He's an adjunct professor here at Cairnmillar Institute. He has over 25 years in private practice as a clinical psychologist and psychotherapist. He and his team developed and implemented a range of clinical programs in public health, including the Agile Psychological Medicine Clinics at Monash Health. He's also held responsibility for clinical education and postgraduate student and psychology registrar programs in a major health network here in Victoria. I want to ask you so many things, George, but I'm going to try and contain myself, particularly to your interest in common factors research in psychotherapy in particular. I know so many therapists are wedded to their approach, and others are so confused by what this research means in actual practice. It's incredibly easy to feel alone working in mental health, particularly when we're facing an onslaught of new and often conflicting information about what does and doesn't work. So I also want to ask about your struggles and failures and how you've met them in relationship to this idea of what the fundamentals are of good therapy. Because you've done a lot of work in that common factors field, particularly with the therapist effect, the thing that I'm really curious about is, why is it so hard for people to take this research on board? Why is it such a challenge to people working across the mental health field that there is, a common thread of what works in therapy rather than kind of one method being better than another?
It's a really fabulous question, and I might not give completely a satisfactory answer, but I'll try and think about, both from a personal journey perspective about, what's happened for me as a psychotherapist over the last couple of decades, but also what's happening in the profession and what happens in clinical research, because both our training programs and the research lends itself to a medical model of training. And, whenever we think about, the hierarchy of health professionals, you think about, you've got your allied health, you've got your psychologist, then you have, endorsed areas of psychology, and then you have psychiatry, and, and everything tries to lean into a medical model approach to to thinking about psychotherapy and thinking about interventions.
Yeah.
Also, a lot of the research spent in very heavily in clinical research into particular what I call specific action approaches around therapeutic outcomes.
Yeah,
so
does CBT work?
Yeah, CBT work, does ACT work, mindfulness work, does psychoanalytic or psychodynamic therapies work. So they are all really, there are camps and research traditions and clinics and people who obviously, and for very good reasons in some ways, very much interested in, looking at what is it about this approach that I've trained in, learned, mentored, does it work?
Yeah.
Right?
There's so much investment on every level.
On every level.
Yeah.
On every level. And so what that, even though I do think there is, you will hear in all training programs the relationship is important, or the therapeutic alliance. You'll hear that. You'll hear, when you train, you'll hear, first of all, establish rapport.
Yeah.
Right? And so these are things that you will hear in your training from the very beginning.
Yeah.
It doesn't matter whether you're doing a counselling course, a psychotherapy course, or a registered profession report, APRA registered profession kind of training. But to say first you establish rapport, that is not a small thing.
No.
And when we're working, we know that establishing rapport is really where a lot of our effort is.
Yeah.
So, it's not that think about the common factors, or I think more now in terms of Wampolt's contextual model rather than, the medical model, but he drew very heavily. The common factors were first mentioned by Rosen, I think 1937.
Yeah.
Then, of course, a really seminal book by Jerome Frank called Persuasion and Healing, and really it was from that where this, a kind of a meta kind of perspective that most people come to us because they're demoralised.
Yeah.
Came, and from that really the various contextual factors. They are discussed in our training, but nevertheless a lot of our training is still focused on specific factors.
Yeah.
Right?
So you've got that whole kind of machine, the kind of research machine, the medical model machine, then you've got the training machine, where, as you say, for many people you've just got established rapport so you can do the thing you're meant to do.
Yeah, do this,
yeah.
and then administer the drug.
Yes,
right?
Yeah. So it's hard then for people to come to the idea that they are the variable, that they are in this relationship, and that they are, the key variable that they've got, some control over, I guess.
Yeah, well, one of the key variables, and maybe we'll talk about that in terms of the common factor. What does contribute to outcome, right?
Yeah. Because
that's the other bit that, if I was to say what's my interest, what do I read, what do I look at, what does the meta-analytic, what does really the research tell us about outcome?
Yeah.
And it does tend to, often when I present around these, I'll often get practitioners come to me after I finish saying, why aren't we trained more about this?
Yeah.
This is what I experience when I talk about it. When I have someone who says to me, and I have to be careful that my colleagues don't, have a dartboard with my face on it, but when I say qualifications doesn't matter.
Yeah, no, they do, don't they? Have a dartboard with your face on it, because that's another challenging thing, isn't it? That it doesn't matter really, and that we don't really train for it. You've talked a lot about your therapeutic failures, and what you've learned from them. And I do hear people talk about that, but what I don't hear is people talking about, well, how do you do that? How do you learn from your failures in the light of what we're talking about? What do you do with them,
Well, sometimes you wake up at 3 a.m. in the morning.
Yes.
In a panic.
Yeah.
Realising that you stuffed something up really badly in a session.
Yeah.
But, I do.
Yes.
I do that.
No, I do too.
Sometimes I ruminate on the patients who got away.
Yeah.
you know, those ones that realise that, like, I mean, look, we don't succeed with everybody, right?
No.
And nor
And
should
some
we.
people we harm.
Well, absolutely, we harm, and not through what I'd call an APRA notification reason,
Yes.
right?
Yeah.
But rather that we harm because any intervention that we ever do with someone, we have to consider harm. When I talk about my treatment failures, I've had them.
Yeah.
You know, I've had people that I think that they could have benefited from psychotherapy. They came to see me, and I just did something that didn't allow that benefit to happen, right?
Yeah.
And so I have to, you know, whilst, you know, again, if we look at the common factors or what contributes to outcomes, we know that 40 to 50% of the variable is based on things outside of what we do, right?
Yep.
So we can never take away that our patients bring or don't bring something with them, right?
Yep.
I'm not talking about, you know, that they're not amenable to therapy. It might not be the right time. They might have other things going on. There's a whole range of things.
Yeah.
But there are also things that we do or don't do that leads to treatment dropouts.
Yeah.
Right, and I mean, I feel that I've got better because I have very few now.
Yeah.
But I still have them.
Yeah.
Even after many years, and always what I've tried to do is cultivate a practice of not shying away from that I can contribute to a lack of therapeutic success. And I think that, you know, I mean, in the outcome research, professional self-doubt is a really important factor.
I was so glad when I read that.
Actually,
this is good.
So yeah, I've got to say it's a little bit Goldilocks, right? Like not too much, not too little.
Yeah, yeah.
You know, like you know, like you need to
Not
have
paralysing
That's
doubt.
not paralysing
Yeah.
doubt where, you know, you're switching and swapping what you're doing with a patient every minute because they've said no, this isn't working, you know, or something. You know, like
Yeah.
you've still got to be able to hopefully sometimes hold the frame in your work, but also be able to be amenable to adaptations of how you work.
Yeah, yeah. So when you're looking at that, when I think of the ones who got away, I think of, you know, the rupture that happens in a particular session. Somebody goes, they don't ever come back, or they finish and that, you know, you don't know why. Like you, it doesn't happen to me as much, but when I think back, I think sometimes it was hard to develop a process to reflect on what happened there. You know, sometimes it's hard to get someone to help you with that, actually, who's really going to go through the nitty-gritty rather than sort of, you know, reassure me that, you know, these things happen. Or because when you say, you know, you learn so much from those, I'd really like to know how to learn more.
Well, I've kind of forced my supervisors to
Have you?
accept that I'm going to do that.
Don't be through. Yeah.
Don't. Yeah, well, you know, like my reflection as you're talking about that is, it's a little bit like, you know, I'm sure that you have too. We've been dealing with a practitioner in supervision or a colleague who has experienced something.
Yeah.
Right.
Yeah.
And of course, you know, it's one of the risks of our profession, and obviously a terrible circumstance for the person who, you know, completes a suicide. But one of the things that I've learned, for example, there is that I remember experiencing one supervisor, and they said, "Oh, everyone said I did everything that I could," and I said, "No, you didn't," and not from a position of, you know, that they did something wrong in inverted commas, but we never do everything we could.
No.
It's not possible for us to have made every phone call or intervened in every bit that we could have made a reflective comment with someone. And so I kind of think that we should always, from recognising that we will miss things.
Yeah.
And we can always do better. And I'm not saying because we can get perfection, but rather that I mean, there's not, I don't know, I'll ask you the question back, right? But sometimes I will have a session, and I'm sure some of my patients will be listening to this podcast at some point, and I've got no idea what's going on.
Yeah, none at all.
Like
Yeah.
but they might come back the next week and say it was really helpful.
Yeah.
What you did, and I just think, what did I do?
Yeah, I didn't even understand what you were saying to me. I didn't understand. Yeah.
You know, like
That you're really having a different experience of that same moment.
yeah,
all the
or
time.
I'm confused. Just, you know, I'm just holding on
Yeah.
in the session, and hopefully that, you know, that's going to be enough, because to say something, there's nothing formed for me, or I'm not sure what to say, and so I'm holding on, right, really in the session, and yet there's something that my patient has experienced that may have meant something to them.
Yeah.
Well, how do we allow ourselves to talk about that?
Yeah.
I mean, now one would say I could put a name on that and say, well, that's transference, right?
You know what? There's a few things that might not fit into that box
That's
as
right.
well. But yeah.
That's right.
Yes,
That's right.
Yeah. Or, you know, I think you're also talking about that space, and maybe that's the doubt balance of being able to communicate somehow your intention to understand.
Yes.
That you want to, you know, what my kid said to me years ago, you did a really bad job of that. She said, but you were trying. I really felt like you were trying. And I think, okay, that's worth something. I mean, I know as a client, I appreciate that. I think someone is really in the ring with me, and they might be doing a crap job right now, but they want to do a good job.
Well, and that matters, I think, doesn't it?
It does.
You know,
Yeah.
like, I think it matters, and, you know, our patients, our clients, hopefully give us some leeway because we are trying, and that they have had a sense of felt, you know, understanding. They experience a sense of acceptance of whatever they bring, and therefore we have, you know, what I describe as a like a band of tolerance, you know, like that. There's a stretch that allows us to make those in session, but sometimes, you know, sometimes larger ones where someone says to you, hey, I really felt you didn't listen.
Yeah.
Right? And this was the effect. Or there's an acting out of session, and then they come back and you think, oh, Jesus, I really stuffed up that last session.
Do you have things that you think, you know, like if I look back, I think I consistently underestimated people's attachment to me. If that's like, if I could summarize some of the big mistakes I made early on, that was one of them. And I think it took me too long to pick that up, or I would have liked to pick that up earlier. Do you have things like that you think you did early on that were, you know, your failures or your blind spots, and how did you kind of turn some of them around? And I'm assuming you have, because, you know, things have gotten better for you, or you've seen improvement.
Yeah, I have. Look, yes, I have. And I think the reflection that I have about, you know, what might be different for me now is that in my younger practicing days, I was really determined to adhere to protocols.
Okay. Right.
Right? I was much more into this is what I have to do.
Yeah.
And I didn't allow cultural adaptations. I wasn't able to particularize what my patient is suffering from, and my explanation and what I'm saying are the therapeutic actions does not match what works for them. Right? It's no use when someone comes to me and believes in, say, you know, voodoo, that I say, don't try and provide an explanation of what they're suffering that somehow leans into that belief.
Yeah.
Right? And so I think that was very much one of my difficulties. And Zoe, the other thing too for me, and I was thinking about it as we were going to talk today, is since I was younger, I've suffered. You know, I've experienced losses in a way that I hadn't when I was 23.
Yes.
I've experienced pain in my own life.
Yes.
And I just think that I understand it more than when I was younger.
Yeah.
And I don't think there's any shortcuts to that experience, right? Like, I know what it's like in my own way when someone dies that you love.
Yeah.
I didn't know that when I first was practicing.
Yeah.
So I think that's changed how I work.
Yeah.
I could put in a name of, I have more empathy, I have more compassion.
It's not very helpful though when you put it that way. It's not, when we think about, okay, this is some of the limits of training, the rigidity of protocol, the absence of ways maybe to tap into those personal experiences or to understand that they're important. The cultural adaptation that you're talking about too, that we maybe have a bit more training now than when you and I were training, but still not enough. But it makes me think of, I think it was Wampold who talked about the super therapists. I don't know why I find that term annoying, super shrinks or something. I know what they mean. But when he talked about them being willing to go outside of the box, and I imagine what that means is outside of treatment protocols, or that you're thinking about something that's not necessarily unethical or even particularly unorthodox, but that you're thinking, how can I adapt to this person? And so do you think over time what happens is that you become more responsive to a wider group of people, is that something you see having happened over time?
I think so.
Yeah.
Yeah, I think so. Yeah, I think you've put it I think you put it really well, because I think that is what we train to be non-judgmental in our work, but actually I think about I was a lot more judgmental back then than what I am now. Right? I think that I have greater openness to the different suffering, different causes of suffering, and not necessarily being able to assume that I can understand someone's suffering. Not to raise the issue, but if we think about the divisions happening about what's happening in Gaza at the moment, that's a real. Obviously that comes into our consulting rooms.
Yes, it does.
Right, and what I was talking to someone just the other day about it, is that what I realise is my privilege that I hear all the discourses, right? Because I don't engage in polarised. I have to listen and bear.
Yeah.
And there might be times I'm hearing someone and I want to think, but
yeah.
that's not for me.
Yeah.
Right? And so I think that just being able to have that greater openness now, I have to be honest with myself that I think that I do that more now than what I used to, and probably a whole range of things, that have allowed that, but maybe just being in a room for so long with so many people that you hear that suffering takes many different paths, and being able to adapt to what might work for this person is what I'm saying, why you're suffering, or even if we co-create that why. And then, when we move to quickly just say, because I do a lot of work around classical, let's say PTSD as a diagnosis, right? But however we want to think about that. And I will use, for some people, I will use absolutely a protocol, which is a specific action.
Mm-hmm.
And then there are others who just will not do exposure work.
Yeah.
Right? For example, which is regarded as par excellence the approach for PTSD, right?
But big
exposure,
dropout rate for exposure therapy. Yeah.
That's
some
right.
People don't. Yeah.
And I will then not use that approach, and we will then do long psychotherapy where, and they get better.
Yeah.
Right?
Yeah.
So I'm missing out on that specific ingredient of exposure, and yet there's something that still happens.
Yeah.
And if I forced it, then they just wouldn't be getting any treatment.
Yes. Yeah. It's interesting when you talk about, that the relationship between that responsiveness and that evolution that you had as a psychotherapist from, let's say when we were younger, and we knew more. We knew more. We were more judgmental. Yeah, and the different varieties of pain, or sitting with the different varieties of pain. But also, I think you're talking about when you do that, or when you've done that, you also see the common factors in action, maybe, that you see the surprising cures, for want of a better word. You see that people get better with no good reason, in relation to the training that you had. How did that happen? How is my client able to use the elevator now? We did no exposure whatsoever because she wouldn't touch it with a barge. Something else was happening.
It's humbling, isn't it?
Yeah.
And you also, I think, when you say that, I think about it also then gives one, hopefully not a hubristic confidence, but that it's okay to work that way, right? Because in some ways, yes, we start to see that we don't have to be in this very prescribed kind of role where we do something very specific, and actually that we, not that anything goes, but that there's more ability to respond to what the patient or client brings and to adapt. And I know we talk about being authentic. I guess I'd say I'm more comfortable being me, whatever that is, in the room.
Yeah, what does that mean? Because I think when you're talking about your trajectory, I think I would have thought about it early on as kind of authenticity as sort of self-disclosure or something, and now it feels to me less like, let me tell you about my life outside this room, and more about the way I respond, or I don't know, what do you think about that?
I think it's about those things, and I think about, not to get too theoretical, but Foucault talks about how to become one's own lawmaker, but that's not without being inducted into the law, right? Because people say, oh, that's lawlessness, so we're all sovereign citizens, for example, right? No, what I think that the way that I read that is that I was inducted into the profession, into my training, but now I have stepped from that training into what my clinical practice shows works, right?
Yeah.
And so when you talk about authenticity, for example, I was trained that suggestion is a bad thing in therapy.
Yeah.
This is a classic example, right? But what's the difference between suggestion and expectancy effects or instilling hope? That is that people come to us and this is a really strong common factors CT factor that's important, which is expectancy effects, right?
Yeah.
It's really important. It's a strong, hasn't been researched as much as the Alliance, but it shows really strong effects on outcomes. What is expectancy? It's when someone comes, we can work with them to say, hey, I think I know why you're suffering, and I think coming, and if we do this and this, I think you're going to get better.
Yes.
Right?
Yes.
I think that, we instill hope.
Yeah.
Hopefully not, blind hope, right?
Yeah.
But I do that now in a way that I would not have done because I thought it was
bad.
That placebo's bad.
Yeah.
Well, why is placebo bad?
Yeah.
If someone can get on with their lives and leave your consulting rooms and have a better quality of life, or have their symptoms are less severe and they're able to get by in the world, that I think that's a good outcome.
Yeah. This is like my dream job now that we can talk about Foucault. Sorry, I won't go down that road further, but it's a lovely, I think, image of, what you do with your professional training, and it also sounds like you're talking about a process where more and more you're less concerned with how it happens. Not that you don't want to notice, but you're less concerned with the mechanism.
Yeah, I'm less concerned that if we do, it's not that I spoke about this before. I have some protocol-driven psychological treatments that I use.
Yes.
Right? It's not that I'm without what would be called specific actions.
Yes.
Right?
Yes.
I have some in my toolkit, not as much as my junior anymore than I do, but I have some, but I don't, I kind of really will draw them out depending on where my client is at, and whether it's an explanatory action on my part which will lead to kind of healthy actions on their part, that they will engage in something that will make their life better.
Yes, yeah. So it's also, I think, it's making me wonder about, because you're talking about your more junior colleagues, you're talking about where you've come from. How do you think we support people more to be able to go through that journey of being able to, I suppose, let go more the rigidity of protocols, or focus more on the common factors in their work? What supports that for you, do you think?
I mean, a few things. Sometimes they'll roll me out at particular training places to, to talk about these things. My supervisees that I have, who, I don't supervise any more students or interns and stuff. It's more that I have more people out of practice, in practice for a while. But even with them, when they'll say they're doing work where with a patient who's got comorbidities, say child protection involvement or youth justice, or had a low prevalence problem, and also say drugs or alcohol dependence, and they'll often say to me but I'm just using a relational approach.
Yeah.
And I'll say, why is the just there?
Yeah.
Right?
Yes.
And so dealing with my colleagues who are really doubting themselves, I'll introduce them more into the common factors. I'll talk to them about what does the outcome research say. So I kind of continue to return to let's look at evidence.
Yes.
Let's look at evidence. And I know that I've talked to you about, and it's been a while, but the National Institute of Mental Health study, the one that looked at comparing CBT with IPT and psychiatry, right? Like that for me is like a gold standard.
Yes.
And they're still digging into that in various ways. And I'll often get people to read that and the fabulous finding of a therapist effect that the psychiatrists who had better therapeutic alliance and weren't administering drugs did better than the psychiatrists who were administering the drug.
Yeah.
And yet that was not in the initial cut of that research paper. They had to then dive in and to look at the therapist effect to be able to draw and tease that research out, those findings out. It's really, if you're medical model would say the therapist doesn't matter.
Yes.
Right?
Yeah.
It's not a variable. Well, it's in the outcome research is about 8% of the variance.
Yes.
Now people say 8%. 8% is huge.
It is. Yeah.
So it's a really large variance of outcome.
So it's kind of like when we're looking to the future or supporting people, you're talking about this thing I hear all the time too, which is I'm just using a relational approach. So picking that up with each other really, and not just kind of delving into what does that mean or what are they doing, but really bringing that research to the fore and saying let's look, when you say that I'm just using a relational approach, let's look at the really solid evidence for what that is and why that works.
Yeah, because when they're saying that, what they're saying is that I'm not using a specific action.
Yeah.
And in fact, a relationship approach has more impact on the outcome than the specific action.
Yeah.
But what people will say is, I'm just using a relationship approach. Exactly. So how do we say, well, that's not a just?
Yeah.
It's not a just.
So we take that from the margins to the center. Thank you. Thank you for listening to How's That Working For You, a podcast for the therapy curious. This has been your host, Dr. Zoe Krupka. This podcast is a space for open conversations, but it's important to remember that what you're hearing are the personal experiences and thoughts of me and our guests. While we're here to share insights, please don't take any of this as advice. We're all wonderfully unique, so if you have therapeutic concerns, it's best to chat with your healthcare professional.
This podcast was brought to you by the Cairnmillar Institute. For more information about our organisation, the services we offer and how to donate, visit our website at cmi.edu.au. You can find links and more information about each guest in our episode show notes. Find us on all major podcast platforms and stay tuned for more inspiring episodes.